Hi, it's Gemma here. Today we are talking about one of my absolute favourites, which is the abdominal system. I'll just give you a second to have a look at this beautiful video. It's not actually a video, sorry. Beautiful picture of a human body that has been cut open like a fish. Look in there, we have the big massive liver. It's very important for you to understand how big these organs are as well as where they're sitting, because when you come to do your examination on the abdominal system, you need to know exactly where all the organs are, what lies on top of what, how you can actually get referred pain, etc. So if you didn't do too well in your A&P, it's a good idea to have a little it's probably a little picture up or something like that in your room so you can revise the organs of the abdominal system. Okay, so today what we're going to do, the usual thing, going to have a quick look at the A&P, remind yourselves about it. We're going to look at red flags and the history taking. Just so you know, in the abdominal system, the history taking is absolutely vital. So if abdominal is your OSCE, I want you to be spending at least 15 minutes on history taking. There's so much to ask. We'll come on to that with some beautiful pictures anyway. We're going to have a look at common and uncommon findings, and as per usual, that will be in your homework table. I'll give you a go at those. And then there's the enhanced assessment. So in this video, I will bring up some particular special tests that we do in the abdominal system. I will create another video which is of the advanced assessments. Okay, so we will do all of this, and then as usual in our simulation sessions, we'll have some case studies and we'll get you to practice the various tests. I need you to look at all of the videos in this section because some of them are really quite difficult to explain in words, so you need to actually watch a demonstration of them. So first things first, we are going to use the usual approach for this, and as usual we start with the hands, work up the arms, look at the face, neck if we need to, then the body, then the peripherals. So as you know, in the cardiovascular and the respiratory system, when we looked at the chest, we did an IPPA model, which is the inspect, percuss, palpate, auscultate. However, in the abdominal assessment, you will auscultate before you start getting hands-on. The reason being is because you do light and deep palpation, and if you're doing that and there's a bowel obstruction, you might upset something further. So it's a good idea to have a little listen before you start poking around. All right, so as usual, end of bed assessments, the verbal primary survey. I want you to be doing this in class. I want to listen. I want to hear everything that you've got to say about the end of bed assessment. Have a look at red flags, history taking, observations. Again, I want you to be doing your best work. So when a person describes to you that they've got a sign or symptom, I want you thinking logically, which observation comes first? Is it time critical? You know, in the OSCE, it's not going to be time critical. However, while we're looking at things here, it might be time critical. You know, we might slip in something there that you would probably say, oh yeah, this has got a high news score, I'm taking it directly to hospital, but I still want you to carry on the assessment. So as if maybe you are in a fast response unit car, and you're waiting for the truck to arrive, so you've got a little bit of time to do the enhanced assessment. The enhanced assessment itself will be on a different video. However, we do touch on some of the special tests within this presentation as well. Okay, so the red flags of the abdominal system. I want you to take a moment and think about them. Try and think about what kind of conditions might be associated with them. Now, don't forget that a red flag is a complete warning sign that something quite sinister could be wrong. So a red flag is not one thing on its own like a high pulse. It's a high pulse with something else, an infection with something, abdominal pain with something. So think carefully about it. So first one I've put down here is the AAA. So some of the signs and symptoms you might have with AAA is this ripping sensation it's right in the center of your chest. It can be felt in the back. Sometimes people describe it as if there's a tearing inside them. And you know why? It's because it's true. So their aorta, the big major blood vessel, might have a tear in it. It might be ruptured, or it might have an aneurysm in it, a little bulge outside of the blood vessel. Either way, the blood is leaking from that. So you'll find quite a lot of red flags that might be indicative of a AAA. This will come up in your homework, but some of those might be pulses beating at different intervals. They might be blood pressures with a systolic of a difference of more than 20. They might be really low blood pressures. They might be the pain. They might be the pallor. So look into all the signs and symptoms of AAA. Pulsating mass is something that we see, not all of the time, but this can be the blood leak in the aorta. If you see a pulsating mass, don't poke it. Please don't poke it. Note it. Have a look at it. Get them into hospital quick. All right, appendicitis. We're going to do a lot of work on appendicitis today. So first thing you're going to see with the red flag is where is the pain. So the pain starts in the right side, and it's between the hip and the belly button. Or in more professional terminology, it's between the umbilicus and the greater trochanter. So you can measure McBurney's point, which we'll come on to earlier on, and that is sorry, you can't see where I'm pointing, but that is exactly where the pain is for appendicitis. Along with that pain will be the signs and symptoms of infection. Appendicitis on its own doesn't always be life-threatening, but a ruptured appendix can be life-threatening. This can lead to septicemia. An obstruction of your intestines. Now, that might sound quite non-sinister to some of you guys. Yeah, it's a little bit of blocked poo or constipation or something, but if that carries on for a long time, your digestive system is not working, and this can be time critical. It can be life-threatening. We'll come on to a little bit more about that, both in your homework and when we look at the different beautiful shades of vomit. Exciting. Pancreatitis, we're going to talk a lot about that. It's not just for the alcoholics. Pancreatitis can be present in people that don't drink at all. It can be really, really severely pain, and with any infection can end up as sepsis. So please don't disregard it if you see a patient that has got a pancreatitis or pancreas pain, even if they've had pancreatitis multiple times before through alcohol consumption. Ectopic pregnancy. Going to look at that in your homework as well. But the red flag for this is the shoulder tip pain, really obscure. So we're going to have a look at referred pain as well. But if you have a patient of, say, a female patient of childbearing age and she has got shoulder tip pain, think to yourself, could it be ectopic? Because this could be fatal. Intussusception is something mostly associated with pediatrics, and we will come on to that in our pediatric session. But it's worthwhile that you noting this jelly-like stool. It looks like blackcurrant jam. And when you come across that, whether it's in a pediatric or in an adult, knowing that that kind of poo is a red flag. Abnormal observations, like I say, in conjunction with something else. So the history taking is really, really important in an abdominal assessment. When you think about just abdo pain, you know, people say, oh, I've got a pain in my tummy, whatever. A lot of us don't think it's anything serious. A lot of us are like, oh dear, it's a wee bug, sure, not to worry about it, I'm sure it'll go away. Or, do you eat fish? Yeah, bit of food poisoning. It's me. That's what I think. It's always the fish's fault. However, it can be really, really significant. And if you can't explain what's causing the abdominal pain, they need to go into hospital, especially with male patients. So these are a few of the headlines for history taking. As usual, you should be using your history taking mnemonics. So you should be doing for pain, either Socrates or OPQRST. You should be doing normal history taking using either sampler or the medical model. And you should be using generic history taking such as MJ Threads and Jackal. I want to see you using probably 3 frameworks when we do the abdominal system and simulation. Really important. Right, let's move on to some of the more specific questions. So beautiful pictures, and let's give you a little bit of an extreme alert. There is one that's a wee bit minging, or maybe more than one, but I shall tell you when it's coming. So first up, surgical history. Anyone that's using the medical model is going to employ this anyway. If you are one of the people that prefer sampler, it's really, really important to ask if the patient has had any surgery. And that's not just surgery in the last 3 months, thinking about PE. This is surgery anytime, even if it's something simple like a laparostomy. You need to know why. What were they looking for? What did they find out? Even if it's something like a cyst, this is really vital. So ask them, have they ever had any surgery? Have they ever had abdominal surgery? When was it? What was it for? Were there any complications? Were there any follow-ups? Really important. Okay, the next one, sexual history. So this can be a little bit cringe, but it doesn't have to be. You're a medical professional, all right? So you shouldn't really feel embarrassed asking these questions. The trick is, how do you get the patient on their own to ask them? So I guarantee you, if you have like a 12-year-old, you will not want to ask this in front of the parents, but the parents are going to have to be present for the legal reasons. So it might be that yourself asks these questions whilst the crewmate takes the patient relative and asks them about the, I don't know, medical history or something like that. Really, really important to be able to get the pediatric or the adult to trust you and give you the correct answers. Don't assume that because of someone's age or because of their setting or because they're posh or because of their ethnicity or their culture or their religion that they're not sexually active. Ask them. You'll have to ask them, are you sexually active? Have you ever been sexually active? You're going to have to ask them, do they use protection? You're going to have to ask them when the last time was. Even with people that are having non-penetrative sex, sometimes you need to ask them about the toys that they use. Not necessarily about the toys, sorry. I mean, if they use toys, because you can still have sexual infections that aren't necessarily from genitalia. Right, so a lot of questions going on there about this sexual history. Pregnancy. Is there any chance you could be pregnant? Now, most of our patients say no. I would like you to follow that up with, could you tell me why? You know, so it might be that they say, well, I'm not having sex. Or it might be that they say, well, I have my period, so obviously I can't be pregnant. That's not true. Oh, yeah, well, there's no chance I could be pregnant because I'm on the pill. That's not true. No chance I could be pregnant because we use condoms. That's not true. So although they're telling you there's no chance that they could be pregnant, there might be. So that's why I would encourage you always with a follow-on question. What's next? Here's one of the maybe disturbing ones, menstrual. So you should ask the female patients if they have started their periods, when their last menstrual period was, if it's regular, irregular, anything abnormal about it, if they're having abdominal pain. We do actually get called for periods. We do get called for period pains. We get called for first periods. We get called for poor kids whose parents haven't even told them what period is. So be expecting to ask about this. And again, don't be embarrassed. Again, you might have to take the pediatric patient away from the parents, but it's really important to know. Again, this links in with the pregnancy one. If they haven't started their periods, there's no chance they could be pregnant. Urine colour. So it's not just the colour. There's a whole series of questions you can ask somebody with abdominal pain in regard to the urine. So we're thinking about urinary tract infections. We're thinking about sexually transmitted infections. So urinary tract infections, you have got bladder infections, kidney infections, cystitis, any type of urinary tract, ureter, loads of them. So you want to be asking about the urine. You want to be asking, is there any strange smell? Is it a strange colour? Are you going more frequently than normal? When you go, is there just a little bit or is there loads? Does it look, I've probably said this, does it look a strong colour? Is it a normal yellow or is it more concentrated? Is there any blood in it? Does it burn or sting when it comes out? Has your pain relieved whenever you go to the toilet? How long's it been since you went to pass urine? So urinary retention is a big deal. So if they haven't been to pass urine for 12 hours, it's going to be getting more serious, especially in pediatric patients. So really ask as much as you can about the urinary symptoms. The next one is bowel. There's Mr. Hank the Christmas Pooh. Don't know if any of you are old enough or weird enough to watch South Park, but he's a pretty cool character. Anyway, we want to know about poos. I want to know about poos. I don't necessarily take a Bristol stool chart with me, but that is something to look at if you are interested in the digestive system, which of course I am. So the general questions are: any diarrhea, any constipation? When was the last time you opened your bowels? And when you did, was it normal? Was it harder than usual, softer than usual? Was there a lot of fluid in it? If you're having diarrhea, is it all fluid or is there any substance to it? What colour is it? So there can be a lot of key points here in the colour of faeces. So we look at black tarry poo. If you ever see that, or melena, blood in the poo, it stinks, but it's also indicative of a lower GI bleed, which is an emergency. So you might not want to ask about it if you're feeling a little bit delicate that day, but you need to. You need to know the consistency and the colour. When you're asking them if they're constipated or when the last time they went is, ask them, is this normal for you? Some people poo 3 times a day. Some people poo once a day. So you don't judge it on yourself. You know, if I poo 3 times a day, does that mean I'm normal? Not necessarily. Someone else that poos once a day might be normal. So judge it on what the person normally does. If they've kept it for you, yeah, you can go and have a look. They might notice a strange stench as well. They might report that to you. If they do report that to you, take it seriously. It doesn't just mean, yeah, they've been eating eggs. It could mean something else. All right, so take that seriously. Okay, so the next thing I've put up is trauma. So it might make you feel a little bit sick. If the poo chat hasn't already made you feel sick, here we go. Ooh, look at this. This is an evisceration. So what that means is this person has had a little bit of probably a penetrating trauma and their intestine has come out. And this does happen to people, and you will see it when it comes to stabbings and things like that. Obviously, you're going to have a look at this. You're going to think about, what am I going to do with it? Why did it happen? So when it comes to a situation like this, dude, you're going to need to dress that. You're going to need to put saline on an Inco pad and scoop it up and bring it into the hospital. You might have other signs of trauma. So the other signs of trauma are bleeding externally, but more likely bleeding internally. So when we come to do the enhanced assessment, you can actually have a little feel of the abdomen like you did in H's and T's for hypovolemia. You can feel if there's any internal bleeding. When you're having your inspection, you might see signs of bruising. There are particular bruises that we'll come across in our IAPP, such as Cullen's sign and Gray-Turner's sign. These can be indications of trauma, but at the same time, they can be indications of severe acute pancreatitis. So when you do your inspect, auscultate, palpate, percuss, really take it seriously with the abdomen. If you have this in your OSCE and you miss one of those out, that's a fail. Right, so trauma, let's get over that. There are some rare circumstances. So FGM, I'll be putting this into your homework, but you need to know the signs and symptoms and things to look out for FGM. For example, abdominal pain. You mightn't be told that there's bleeding. However, you might have to ask these questions. If you have a person that's of that age, or if your index of suspicion is high, ask about bleeding, ask about any procedures. This might come into your surgical history. It's a very delicate topic, and one which is associated with people who are culturally strict and might not want you to be asking these kind of questions. However, this is really, really, really serious, and our girls can die from associated risks and infections with FGM. So tread carefully, but do try and ask about it if you're all suspicious. And the last one is vomiting. Now, this is another great little tool, a bit like the mucus. What colour is the vomit? So I want you guys to be thinking about that when a patient says they vomit. What colour was it? How often have you vomited? Was it a one-off? Was it intermittent? Was it constant? Was it projectile? What was in it? So thinking about the least sinister ones, first of all, that kind of white or frothy vomit, that's mostly just swallowed saliva. So, or maybe when you're like B and you have an Alka-Seltzer. Alka-Seltzer can, it'll make or break you. And let me educate you a little bit more about Alka-Seltzer. When you take it, sometimes it fixes you, sometimes it makes you vomit. So a bit like a paracetamol, that might come out white and frothy. Swallowed saliva, white and frothy. So if it is white, most of the time it's not sinister. But it's worthwhile noting the colour of the vomit and how often they've done it. Next one, I've written these all down. Food. Obviously, food, not necessarily sinister. With food poisoning, you can get that anytime really up until about 12 hours after ingesting the food. It does depend on what stage of the digestive process you're at, what the food will look like. I'm sure we've all had it before where we've eaten something and then been sick straight afterwards and it comes up exactly the same as it went down. It's totally minging and puts you off that. I had it with spike ball, put you off that for a few months or life. You have ingested foods that is a little bit more broken down by the chemicals. So, for example, I have puked like tea and toast, things like that. When you've got flu, whatever, they have started to digest and then they come up. It's not so bad when you can taste them. Oh my goodness, chilies, curry, those things like that, vomiting. Don't forget, when you're vomiting, because of the mechanical digestion, it's going to be mostly acidic. So these patients will have a burning sensation in their throat. And they will have vomited acid along with their food. So they're probably going to be in a little bit of pain. Okay, next, pink or red. So we know hematemesis, that is blood in the vomit, but we're talking about fresh blood. So we're talking about pink streaks, that kind of thing. That's hematemesis. Sometimes that can be caused by too much retching, by a break in blood vessels. Sometimes things a little bit more sinister. Sometimes you can have blood clots in your vomit. It might be a little bit of a redder colour, or you might see the change in texture. And that can be for something like a perforated ulcer. Upper GI bleeds as well. So they not as sinister as the lower GI bleeds, but still an emergency for somebody who's actually having hematemesis. So you think about what bleeding might be going on. It might be something esophageal. Anyone seen esophageal varices? This is something you're probably going to need to look up for Richard's course, because I think it might be eye gel, but one of the SGAs is contraindicated in esophageal varices. This is basically where you have like varicose veins in your esophagus. One of them ruptures and it is like horror film. It's blood. The one I went to, it was like the walls were painted red. Amazing to see, but really bad prognosis with esophageal varices. Anyway, I'm digressing. Let's move on to brown coloured vomit. So I'm reading some notes, by the way, that's why I keep looking down. So the brown colour vomit, sometimes it can be something just as innocent as a milk intolerance. However, it can be bleeding as well. So if you're looking at brown vomit or black vomit, we're thinking this is lower GI. And that's a bit more serious. A lower GI bleed could come out as brown vomit. It could come out as black vomit. Most of the time it comes out as like coffee granules. That's what people describe it as. And that's serious. That's not good. That's a lower GI bleed. Fecal vomit. For real. And I have seen this too. So fecal vomit, a little bit of poo coming out your mouth, absolutely stinks. But anyway, can't imagine for the person what that feels like who's actually vomiting it up. Never mind what it felt like for me to smell it and gag. When that's coming up, it's extremely serious. There's an obstruction in the intestines. This is a time critical. If you ever see it, get that patient into hospital. Other ones that you might see, acid reflux might be white coloured. Fungal infections might be black coloured. I hope somebody does vomit colours for a dissertation topic. I would love to read about that. This is really interesting to me. I also like poo. All right, moving on. Referred pain. So I did touch on this when we talked about ectopic pregnancy. What I want you guys to do is to look this up. I don't want you to just simply accept it. So I have got shoulder tip pain. I could be having an ectopic pregnancy. Do your best work. Ask yourself why. Why does it work like that? What has a shoulder got to do with an ectopic pregnancy? You know, some people are like, oh, reflexology, mumbo jumbo. How can you get rid of a migraine from massaging the big toe? I'm not saying that that is a thing that you should believe in. However, referred pain is. Let's look at this. So basically what this means is the pain is received at a different site. So like the shoulder tip. It's the result of the interconnecting sensory nerves. So it's a nervous system issue. It's not a malfunction. This is the body working correctly. Sorry, I'm in front of the information here. I'll put up the slides without me in front of it as well. So it is related to the brain. It will give pain elsewhere. And here's a diagram of where you might see it. So this is abdominal pain solely. Looking at this diagram, it can tell you where you might feel the pain for particular abdominal conditions. So some of these conditions you're going to be looking at in your homework table. So it might be a good idea to add in another little column that says, you could probably do it in the abnormal presentations. You could probably write in there, referred pain. So worthwhile noting. A more general diagram. So this is not just abdominal conditions. This is other conditions of the body and where you might find the referred pain. Feel free to pause at this stage. I wish I had a drink. I'm kind of dry. Now, time for you to test yourself. See this chart? These are the 9 quadrants of the abdomen. I say 9 quadrants, 9 areas. A quadrant is located in 4. So what most people do is they split the abdomen into quarters and they call it quadrants. So upper right, lower left. You can do that, or you can split it into 9 if you want to be a little bit more specific. What I want you to do is draw this out and write in where you think any illnesses might occur. So I'm going to show you on the next slide the answers. So it would be a good idea at this stage to pause me, draw out the diagram, and do a little bit of work for yourself. Moving on. So this diagram I am blocking again, sorry. It tells you the names of the 9 areas if you want to refer to them more specifically than quadrants. And it will tell you what is associated, what organs are associated in those areas. When it comes to those organs, you can think about what illnesses come with them. Again, this is a good one to print out, pop into your folder for when you go on placement, but I would also add some notes beside that. So for example, when you're looking at the liver, you might have illness of hepatitis, psoriasis, inflammation. So write down the illnesses that come with each area too. We're going to be doing a lot of work on appendicitis, so it's worth you knowing all the signs and symptoms. So most commonly people will present with a lower right-sided pain. It can come on suddenly and it can be quite a sharp pain. So you can see there 60 to 90% of patients will have a nausea with it, and in the 70% of patients will have an anorexia. And what that means is they won't feel like eating. It doesn't mean a long-term illness of anorexia. It's got nothing to do with anorexia itself. It means not wanting to eat. Quite a lot of the patients are going to get the onset of pain and then vomit. Some people are getting diarrhea and constipation with it, but not loads. Now you'll notice a lot from the patient's position. So this is why the end of bed assessment is really important in this. What position is that patient in? So they're normally curled up. They do not want to stretch that muscle out that's over the appendix, the psoas muscle. They do not want that to be stretched out. If you were to flatten them out, that would give them a lot of pain. So they're quite curled up. Knees are up to their abdomen normally. Flex their hips and they'll lay down. Now the rest here about the tenderness, that is going to be in our specific signs. Also what it says down the bottom there is, let me just move this for you so you can see. There we go. Male infants and children sometimes present with an inflamed scrotum, so one side of it. Next. All right, so for anyone that likes a little visual, here is the signs and symptoms on a beautiful diagram. So that bounce ball there is the rebound tenderness. That's what that is supposed to signify. You can see the position for this guy as well. And also he's got a temperature, sorry, guy, girl, I'm not sure. Temperature and pain, and he's holding exactly where the appendix is, and he looks a little bit grumpy. I'm surprised he's not vomiting. He probably should be vomiting as well. So see down the bottom here, McBurney's point? That is the exact location of the appendix. So I'll tell you how to find that. Whoop. Come on. All right, these are the special tests. Now I'm going to put videos up on these separately, but we have 3 tests here that we can do for the appendix. Most of your information you're going to get from the history, from the location of pain, but these are specific tests that we do. Some of them aggravate it, but in a gentle way. So this will confirm your findings. So basically, with Rovsing's sign, you palpate the left side and you'll feel the pain on the right side. The reason why is because you're moving all the organs over, and that is going to touch the inflamed appendix, and that's going to give you pain. So push down on the left side of the lower quadrant of the abdomen, pain will be felt on the right side. The obturator sign, so what you need to do with this is you need to literally, with this and the psoas sign, you maneuver the legs. We'll show you this in the videos and in class. You maneuver the legs. That is going to irritate the appendix as well. So that's a positive sign. You'll feel that pain over the right side, so over the site of the appendix. It's the same with the psoas sign. What you're going to do here is extend the leg. And again, you're going to be getting that psoas muscle to touch on the inflamed appendix, and that will generate pain in the appendix area as well. Like I say, make sure you watch the videos because I'm going to be expecting you to be able to demonstrate this at your sessions. McBurney's point, as we've discussed before, that is where the pain will be felt. Now, be really careful with palpating McBurney's point. If you're suspecting that a patient has appendicitis, they will not want you to touch that appendix. So very, very, very lightly. We know with pain as well, we start away from the site of pain and end up there. So if you're suspecting somebody's got an appendicitis, I want you to start palpating for the pain very lightly in the lower left quadrant, move up to the upper left, then the upper right, and then very gently on the lower right. So this is how you find it. Draw an imaginary line from the right iliac crest to the umbilicus. McBurney's point is 1/3 from the iliac crest. Light palpation first. Do not move on to deep palpation if you get an extreme pain from the light palpation. Be careful. Right, rebound tenderness, not necessarily for appendicitis, but you might find it positive with appendicitis as well. So ask the patient to point to the pain. When palpating the area, you push down with your fingertips. All right? When you take your fingertips away, and that's when they feel the pain, that's rebound tenderness. So you're palpating. Normally, when you're palpating an area, the patient will go, that hurts. But with rebound tenderness, it's going to hurt when you take the pain or when you take the palpation away. That's when the pain occurs. So that's normally indicative of peritonitis. Again, peritonitis is going to be in your homework. So note that as a little abnormal finding. Cholecystitis, or gallbladder inflammation, is another one that we will test for. This is quite an uncomfortable test. If a patient has got gallbladder infection, cholecystitis, they're not going to enjoy this test. Even if you don't have cholecystitis, it can be a little bit uncomfortable. So lie the patient down flat. They're on the stretcher. Get them to breathe in. Put your hand right in underneath the liver. Ask the patient, breathe in, slip your hand in. When the patient inspires, they will go, oh, and they'll shout out. And that is a positive sign for cholecystitis. This is called Murphy's sign. Again, there'll be a video on this, and you can see the guy going through this and having the pain. I don't think it's fake. Right, so that is a special test in palpation for acute cholecystitis. There are other ways that you can suggest from the history that a patient might have a gallbladder problem. It can be quite offensive, the 5 Fs. If you want to go down that route, don't say it out loud. But first of all, here is the information, and then I'll put the 5 Fs up on the left side or right side of the patient for you. So this patient will be presenting with kind of liver gallbladder type problems. So you're likely to see jaundice in the eyes, maybe in the fingers, maybe in the skin. They're going to have symptoms of infection. So not wanting to eat, nausea, vomiting, fever. The pain will be in the right upper quadrant. It does say it can radiate into the right shoulder and into the right back. So your referred pain might be right shoulder pain. They feel full. Quite often, people will get this after eating certain types of food. So if you live on takeaways, for example, it might be that you're more inclined to get cholecystitis than a person that lives on fruit and veg. And they might be feeling really full. They might be feeling bloated. They might be feeling like, oh my God, you need to just stick a pin in my tummy and pop it. But no, this is the feeling of the cholecystitis. Sorry, I've just seen her chips there. Made me want chips. All right, here come the 5 Fs. So female, fair complexion, 40 or over, fertile, and fat. So yeah, please don't say these out loud to your patient because it's really quite offensive. But this is a very sweeping generalization of what these patients tend to present to you as. This does not mean to say that men cannot get it, or that dark-haired people cannot get it, or that people who are not of childbearing age cannot get it. It's just these are the more likely people to have cholecystitis. Kidney infections. What we do when we're doing our palpation in the enhanced assessment is we feel the kidneys. So what you're actually doing is you're feeling on either side there. You should not be able to palpate your kidneys. Sometimes the right one is a little bit lower down and it's a little bit bigger. So sometimes you might be able to feel the right one. For me, it's normal. I can feel my right one because it's always enlarged. But for most people, you shouldn't be able to feel them. So what you're doing here is squishing them in between your hands. Not squish like that, squish quite gently. You call it ballot balloting the kidneys. And what you're doing here is if you've got a kidney infection and they're inflamed, that's going to hurt. So it's going to hurt a little bit. Do it quite gently. There are more kidney tests. We talk about the costovertebral angle. So again, that's on your back. Remember when you were doing chest expansion in the respiratory, this is where you'll locate your kidneys, where your ribs meet at the back. Your kidney's going to be located underneath the ribs. So what you might see some people do is to do a little gentle thump test. So what we do is we put our hand on the kidney as such, knowing exactly where they are, and a little gentle thud. That's going to hurt if you've got a kidney inflammation. If you've got kidney stones, you might have different symptoms. Some of them will be the same. There will be the pain in that general area around the back, probably more so than the front, but you can have pain on the flanks as well. They might be vomiting. They might have fever, any signs of infection. But with kidney stones, you quite often get the pain when you're trying to urinate. Now, this is said to be one of the most painful things, is to pass stones. So this one is more prevalent in men. You might get blood in the urine, that's hematuria, nausea and vomiting, pain in the flanks or in the front or in the back. And it can lead to sepsis and severe infection. So take it seriously. These patients normally are going to require morphine because the pain is that bad. When they go into hospital, there are several things that they can do. First of all, they will check if they've got kidney stones, normally by an ultrasound, or sometimes it's just probable, so they might treat it anyway. So sometimes they ask you to try and pass them, which of course will be incredibly painful. Sometimes they will use lasers to break them up or medication treatment to break them up, but they'll still ask for them to be passed. So passing that through your urinary tract can be quite painful. So I'll be a bit sympathetic for kidney stones. Right, here's the diagram of what illnesses can occur in each of the areas that we talked about earlier on. So if you did write that down, now's the time for you to check it. Some of these you will never have heard of, but most of them you probably will, and I want you to know about them. When we're doing our case studies, it might be that you think about some of these as differential diagnosis. So it's good to know whereabouts you might feel the pain if you have, for example, a bladder infection. You know, you're going to feel it like at the bottom, in the middle. If you've got liver or gallbladder, you're going to feel it upper right, etc. I need you to know where this is. I do have some horror stories about people from ambulance service missing dreadful things and patients ending up really seriously ill, really seriously unwell, or even fatalities. So please, please, please take abdominal pain seriously. Please look into the conditions that can cause it, and please do your homework. All right, that's it for me. Bye.